We'll wear pieces here. And it's
is Sean Phillips, and I'm the Head of Health and Social Care here at Policy Exchange. And it's a real pleasure to welcome you to the first health and care event in Policy Exchange's Fringe programme here at Labour Party Conference. And the question that we are asking is, how would a Labour government deliver its plans for the NHS workforce of the future? And I'm really delighted to say that we've partnered with the University of Surrey for this event. We know that supporting and indeed expanding the NHS workforce is going to be a top priority for a Labour government. That's borne out by the polling, but also in terms of how Labour has set the direction in this space. We think about the comments and the plans set out by Rachel Reeves last year, the commitment to double medical school places and other key professions as well. So how could a Labour government deliver their plans for the largest workforce expansion in history? What measures need to be considered to ensure that those bottlenecks in training are minimised and so healthcare professionals can be effectively retained over the long term? And ultimately, how will a Labour government handle the fiscal and political headwinds which will undoubtedly come its way? So to consider these questions, I'm delighted to say that we've assembled a fantastic panel. Dr. Adrian Boyle is the president of the Royal College of Emergency Medicine and is a consultant in emergency medicine at Addenbrooke's Hospital in Cambridge. He previously chaired the Quality Committee at the RCEM and was also their vice president of policy. And at Addenbrooke's, he's acted as lead educator and lead clinician. Anita Charlesworth is the Director of Research and the Director of the REAL Centre, Research and Economic Analysis for the Long Term at the Health Foundation. Before joining the Health Foundation, she was the Chief Economist at the Nuffield Trust, and prior to that had roles as Chief Analyst and Chief Scientific Advisor at DCMS, and was also Director of Public Spending at the Treasury. Paul Richards is a Labour activist, columnist and author, previously served as a special advisor in the Department of Health and also in the Cabinet Office and Communities Department. He's been a Labour parliamentary candidate, national chair of the Fabian Society, and has written 4 books on policy and political communications. And he's also Labour's candidate for Police and Crime Commissioner in Sussex. And last but not least, Professor Juliet Wright is the founding dean of the School of Medicine at the University of Surrey. Now, the University of Surrey has been at the forefront of training the medical workforce for many years. They recently celebrated 40 years of nursing, but they also deliver midwifery, paramedic, physician associate, and good psychology programs too. And in 2022, they launched their medical school, which will be welcoming its first students next year, I believe. Juliet herself is formerly the Director of Undergraduate Teaching and Learning at Brighton and Sussex Medical School and has particular expertise in the assessment of frailty and elderly HIV and oncology patients. So I'll be handing over to each of our speakers in turn, starting with Anita, where they'll deliver up to 5 minutes of opening remarks, and then as a panel we'll discuss some of the key themes that emerge, and then it's over to you for the final 15 to 20 minutes. And our only house rule is that you just wait for the mic to come to you and you state your name and organisation. So without any further ado, Anita, over to you.
Thank you, everybody. And I think it's worth noting in what can be a very depressing time that actually workforce policy we have a bit of a turning point and a pivot moment with some ingredients which are really, really positive. So actually both political parties now are committed to a major expansion in the domestically trained workforce. There is cross-party support now for the need to properly plan for our workforce. And the NHS long-term workforce plan, which was published this summer, has an expansion in the workforce, which is, if anything, bigger than the expansion in the early 2000s under the Blair-Brown government. And some of the ingredients of that, I think, also are really, really important. So I think it has now been accepted that undertraining staff is a real problem for the NHS, but also probably a false economy. Yeah, and has actually led to increased cost pressures across our system. And so we need to train domestically. I think there's also a lot of support now for the fact that we need to diversify our workforce and we need to increase the routes into training, the routes into roles, and expand apprenticeships so that more people both have an opportunity to work in the health service, but there are also real clear pathways through healthcare, and so people can have careers. And we can have a workforce that more closely reflects the population that is served. And so those are all really, really good and important things. There are a couple of things then, though, that are real challenges on the delivery side. And I would say overwhelmingly, I don't think there's that much debate about where workforce policy needs to go, but there's a lot of issues about how far we can deliver that. And I'd highlight, I think, a few issues. One is that obviously, essentially, we need a larger share of our working age population to work in healthcare. Yeah? And we need to get more people to choose healthcare in the first place, and then critically we need that workforce to stay. We need to retain more of the workforce. And at the moment we have a workforce with low morale, too many feeling disengaged, we have industrial action, and we have a retention problem. Yeah? And we are seeing that actually applications to some key areas like nursing are falling off as well. Pay is part of that, and what we're going to do about pay for these areas is really important, but also it goes beyond that for the quality of the jobs, the feeling valued, and all that set of issues. And at the moment, I think the definition of the problem is clearer than actually what in policy terms should be done about that. The second issue that I think is really critical is we actually do have a pretty clear policy on the NHS workforce, but actually the social care policy is much less clear. And if anything, the social care workforce issues are even greater. And perversely, fixing some of the NHS issues might make the social care problem worse because we make social care jobs even more attractive. And I'm not arguing to make healthcare jobs less attractive, but we are going to need a social care workforce plan pretty quickly to sit along an NHS workforce plan. And then the third thing that's really important to think, I think, is that we're actually living through quite a change in the composition of the healthcare workforce, which is planned to continue, with much greater use of new roles in healthcare and team-based care. And we're seeing this in particular with primary care, where we've got, I think now 31,000 people in new roles in primary care, and a move to a primary care team, even more than we've had in the past. The same true across our system with some of the allied health professional roles, for physios, etc., all being expanded. But how to work effectively as a team, I think, is still very much a work in progress. And at the moment, actually, since the pandemic, the number of staff going into the NHS has actually increased quite substantially. But the amount of care we're providing has not. If anything, particularly in hospitals, the amount of care we're providing is actually still below that. So actually, how to ensure that the extra workforce that everyone now is committed to are able to work effectively together. We do have really good staff engagement and retention, so that we're able to translate extra workers into extra care. Seems to be really, really critical.
Thank you very much, Lisa. So, Professor Wright, we can go to you next.
So thanks, Sean. I'll just put that there so you can hear me. So thanks, Sean, and it's really nice to be here as part of the panel and to join in the discussions. I'm really going to focus on that small part of this big problem of NHS workforce with respect to medical students. So, as Sean said, a new medical school in Surrey is really an example of one way that training new doctors is going to help solve the problem. One size isn't going to fit all, and I think that's really important. Medicine has been quite siloed in the past, and a lot of the big medical schools are full to the brim. So what should a new school look like, and what can we learn about training doctors, from the past that we could do better? So we are very much looking to our colleagues. As Sean said, we've got a very successful nursing school, midwifery school, paramedic school, and thinking about strengths in those schools to train doctors of the future. So much more team working. Right from the word go, making sure that doctors train with the people that they're going to work with. So 3 points really that I'd like to just touch on is innovation in curriculums, and looking at these new models of working and where digital technology can support that. I think we've got to teach in different ways. A third of medical students plan to leave the NHS when they finish their foundation training, and when we know how expensive it is to train doctors, that really is not helping. And then I just want to touch on the end about a positive and inclusive culture. Again, so important for retaining the workforce. So we were just talking before about curriculums and how it was when I trained, and I think biomedical science really needs to be clinically relevant now. And how can we use technology? So we're planning to live stream surgery to our students in year one, so that they, right from the beginning, learn in the correct way. I learned a lot of anatomy that I've never ever had to use again. So whilst I'm not advocating a decline or a decrease in the amount of science, it's about looking at what matters and where can we use resources, so that first learning happens not necessarily in the clinical environment, which we know is packed, but happens in an innovative way. Our students will go out with the teams in the community much earlier. So in Surrey, we've got a really innovative hospital at home service. So the students actually going out right from the word go, understanding the patient journey, using technology to help support patients, and working with the team members. And those students actually having a role rather than just watching. So right from the beginning, they're understanding the job that they're going to go on and do. An accelerated degree like ours also offers benefits for students who have worked for some time in other healthcare professions who want to take that step. They know what the NHS is like. They have years of experience, perhaps a physio, occupational therapist, and a more focused course, an accelerated course, will support that. Will support that change. Thinking about that retention, some of the unexpected consequences of improving working hours for doctors means that we don't work in teams in quite the same way as we used to 20 years ago. And there is a support network that has been lost as a result of that. So I think as we come through trainings, we need structures, guidance, and support to sort of foster the professional skills so that new doctors think about careers, they think about career progression, and they can realise their ambitions, whether that's in research, whether that's in clinical leadership. And so I think having tutors all the way through that can support students do that is really important. And again, for the existing workforce, being part of that journey, giving them a portfolio career, I think helps retention. And then lastly, it was my colleague Carrie Newlands in Surrey who led the work reporting in the British Journal of Surgery 63% of female surgeons being the target of sexual harassment, which is really quite shocking data. And very important, again, I think that as we train our doctors, that we deal with this head on, that strong professionalism theme, as I was saying, supporting career progression, supporting interests for portfolio careers, means that there's strong role models and that we can train doctors to work in a way that we all should be able to enjoy. So I'm looking forward to taking part in the questions later.
Lovely, thank you very much. And Dr. Ball.
Hi. So I have no problem getting people wanting to work in my specialty. Emergency medicine is seen as an attractive specialty and is always oversubscribed. My problem is hanging on to the staff who come into this, and it's not just actually about retaining the doctors. That's very visible, but I worry very much about, because medicine is a team game, and emergency medicine is particularly a team game, about the retention of senior nurses. There's very little data about this, but we have a nagging concern that we're losing our experienced senior nurses. And we wonder why we're losing staff. And I think it's actually the conditions that we're expecting people to work in, and the lack of autonomy and the lack of agency that people feel when they work in an emergency department. So I still practice clinically. I will be working on call this weekend, and I will work. It's very possible at 10 o'clock at night I will be confronted by a queue of 100 people aged from 1 day to 100 years old with a massive variety of problems, with 4 doctors to see them. And that's my start point, and that's sort of assuming that nobody else arrives over the night, and we know that's going to happen. So my doctors and my nurses work in terrible conditions. So it's a very stressful environment to work, and how we hang on to people and how we give them working conditions. And I do not think I have a problem with retention if we can sort out the environment that people have to work in. People are being looked after, and they feel that they are able to do a good job, they'll enjoy that more. I find it heartbreaking when I leave work one evening and come back the next day and the same patients are there. We've just put out our own manifesto. 400k people spent more than 24 hours in an English ED, not moving on. But I believe this is very much a fixable problem. It sounds slightly shoulder-waving, but I'm the representative of the most burnt-out specialty within medicine. Every year the GMC do a survey, and they've identified us consistently as the specialty at greatest risk of burnout. So we've done a lot of thinking about how we can make things better. I'm just curious in the room, who works for the NHS in the room? A couple of hands going up. Who would describe the NHS as a good employer? Okay. There's hope. There's small hope. Okay, so I don't think the NHS is a good employer. We put all this effort, expect people to go under this enormous amount of difficult training, and yet we don't look after them. And some of this is actually very fixable. I don't think it's necessarily a job for government. Government might have a piece of work to do creating the culture, but simple basic things around treating professionals with respect, with giving them some autonomy of their working lives. You can see it all over social media about junior doctors who aren't allowed to go to their weddings. People who don't get access to hot food out of hours. Basic, simple workforce hygiene. You check into a hotel, it's very slick. They know how to do it. You check into a new hospital where you are rotated to every 4 months, it's not slick. There are things that we can do to create a better culture within our environment. Giving people autonomy, things like self-rostering, is a simple, easy thing to do. It is cost neutral. Probably, actually, it's a cost saving, because if you give people the chance to control their shifts, they're going to turn up for those shifts which they've said, because they'll feel a sense of ownership. They'll turn up, they'll do that work, and you won't need, we spend a lot of money on locums, agency and bank, and that is an inefficient way to spend it, and we need to actually look at retaining our workforce and reducing that spend. That'll be cost effective. There's a difficult piece around tackling culture within the NHS, and I know you brought up the sexual misconduct in surgery. There are isms all over, whether it be homophobia, racism, ableism, and actually, again, these are fixable problems, but it's about creating that culture where people feel that they can call out poor behaviours, and that there's good HR policies, and that they're followed, and that the leaders in our environment are actually in a position to provide a good example. And then the final bit is around making sure we've got people who lead this. One of the things I've observed over the pandemic is people are, to use an American expression, slightly carrying their lunchbox because it's so difficult, because it can feel quite hard. People are feeling disengaged. And the retention is not just people leaving, but it's the quiet quitting, the reducing the hours, the winding down, the going less than full time. I think those may be appropriate defence mechanisms, but we need to actually create an environment where people want to come and work and do a good job. They've done a lot of training for it. We need to invest in them.
Brilliant. Thank you very much. And Paul.
Thank you very much. So I'm Paul Richards. I was a special advisor in the last Labour government, not the last ever Labour government, I hope, but the last one we had. I'm a Labour activist and writer, and I'm somebody who advises some of our health team today. I mean, this is my 33rd annual Labour Party conference. I think I should get some sort of medal for that. I missed the one during COVID, so does everyone else. But we've been debating the NHS for some of that time. Some of it we've been in office, but mostly we haven't. And it does feel like a bit of a pivotal moment where we may be entering a period of government again. So some of these lessons have to be learned. And I suppose my starting point is to say that it's going to be so different this time from last time, although there are some similarities. I mean, if the exam question is how do we do it? And I can answer that in a word. We do it through growth. The only way you're going to get the investment in the public services you want is through growing the economy. And we're all missing Rachel's speech right now, unless you're surreptitiously watching it at the back on your phone. I hope you are. But that you know full well that the theme for her speech is going to be how do we grow an economy, not just in the southeast and not just around finances, but how do you grow it in every part of the country and in every sector. And of course, investing in workforce in the public sector is as an engine for growth in the economy as well, isn't it? Because they spend their money in the private sector and they buy things and houses and cars and so on. So all of these arguments are tied in. When you look at the missions, you start with mission number 1 to the fastest growth in the G7, but only do the others flow from that once you've got that first one in place. So the important thing is the economy. Anita mentioned the TBGB years, which I remember with great fondness. You'll remember those years. The first 3 years of the Labour government, we stuck to the Tory party spending commitment. We didn't have a massive tap turning on moment and suddenly, we got into office and all the money started to flow. We had 3 years of the same spending the Tories had offered. So, of course, the Tories have got allocated resource to their workforce plan now. That is what we're going to have to adopt in government if we are lucky enough to be in government. But then you'll also remember there was a moment, Tony Blair went on the telly and he basically announced that we were going to have the same spending as the European average. And that was code for a massive increase both in workforce but also investment in the National Health Service. And Gordon, you may also remember reading, went absolutely loop-de-loop and shouted at him and said, "You've stolen my budget," with slightly stronger words than those. And there was a political row around it. But Blair knew you had to put the investment in alongside the reform, but that was only really in the second term you started to see that flow through. So there might be a lesson from history there, which is about steady she goes in the early stages of a government. As the economy grows and as things bed in, don't expect, I suppose, too much too soon. And by the time I got there to the Department of Health, of course, we had a massively enhanced and growing workforce off the back of the 5-year plan. And the other little lesson I'll just put in at this point, I hope this doesn't sound disingenuous or bitter, but I also remember my Secretary of State going onto a stage at the RCN and being booed off the stage by an organised intervention from the crowd of trade unionists. And the RCN at that point were both celebrating their biggest ever membership. So the more members of the RCN at any point, is anyone here from the RCN, by the way? Good for you. More members than ever, and at the same time denouncing the Labour Secretary of State and their policies which had delivered it. So looking back on that period, it was something of a golden age, and it did, as you all know, lead to the highest levels of NHS satisfaction in its history. But at the time, we still had to go through this pain of reform that was not always been wholly welcomed. So anyway, we need to address this. And I'm talking to Wes and talking to Abena and some of the others in the team. I think they get it. They get the 3 R's. They know that we have to recruit, they know we have to retain, and they know we have to reward the NHS workforce. And of course, they're all interlinked. And I think retention is going to be more salient this time than last time because, as we've heard and we know from our own experience, burnout, mental health issues, people doing far more hours than they're supposed to, people getting better reward in other sectors and other areas, and even moving abroad even, that's a much bigger issue now than I think it was in the 2000s. My friend Caroline lives up the road, and she is somebody I've known since school, and she works in the NHS in Merseyside, and had a cup of tea with her the other day, and she said after 25 years she's left the NHS just through sheer burnout. She's a highly specialised, experienced NHS professional, but she just couldn't do it anymore. She just couldn't cope anymore. And she's at home and she's depressed, and her NHS identity was her being. That was who she was, she told me. And yet she had to make that heartbreaking decision. Now, we all know Carolines, don't we? I mean, there are people in this room in that situation. We all know them. You employ them. This is what we're talking about. So I don't think retention was as big a deal as it was for TB and GB, but I think it definitely will be for SKS and the rest, WS. So that issue. And then, of course, reward. We have to sort out the pay, and we have to settle these strikes early doors if they're still going on. But it's more than just money, I think. I think it's about terms and conditions, and also that sense of esteem, I think. Because, you saw Sunak attacking doctors in his speech last week, and some of the media briefing around the doctors' union and so on. It's just entirely unhelpful and unnecessary, and it lowers the esteem, which, of course, feeds back into the recruitment and the retention, doesn't it? It's all interlinked, as I say. So there we are. That's my points around that. My final point is 33 years of coming here, the Labour Party, I'm afraid, this is a tough truth, has fetishised the NHS. We are obsessed with it. And Lawson once said, Nigel, not Nigella, once said, it is our national religion. That's what he said. And I think we've adopted this. I think we have to break out of this as a party, and we have to talk far more about public health, about prevention, about all the social determinants of health. And so I'll finish by reminding you not of pledge number 1 or national mission number 1 on growth, but actually the one about health, where it says we are going to tackle these health inequalities. Because if you want to actually inculcate a proper public health policy, it isn't about workforce, it's about the working population. And young people having a breakfast, and older people being able to swim, and all the things we know that count. Deep issues of social justice and class come into play here. And so just talking about the NHS, I'm afraid, is an important but not only component. What is far more important are the things like I was involved in, like the smoking ban, arguably the most important intervention in public health in 30 or 40 years, which was something that the government didn't cost a penny. And by the way, final point, we put money aside in that year for the police. in order to do the crime, arresting smokers in pubs. There was a police budget ready to enforce the smoking ban. How many arrests were there? I don't know, less than 10? How many? Not many. Because the public was ahead of us as ever. They adopted the smoking ban with alacrity and no one wants to go back. So I think on some of these big public health issues, as ever, the public is ahead of where the public policy is. Thank you very much.
Brilliant. Thank you very much. Lots of fascinating points. I'll perhaps just put a quick question to all of you. Anita, first, I was really drawn to this point around you mentioning around a false economy. The approach up to now has been a false economy. And the Health Foundation did some really interesting work recently looking at that longer-term changing burden of illness in society and what that's going to mean, and that necessitates a changing level of demand for healthcare. I just wondered, from your perspective, how future governments are going to manage that clinical need, I suppose, and the need for the workforce, but also balancing. The Institute for Fiscal Studies put out a report a couple of weeks ago that said 1 in 9 public sector workers, if this plan were to be delivered just on the NHS alone, that ignores the social care piece, will be working in the NHS. So I just wondered how we're going to balance that tricky.
Yeah, and it's worth saying, I think, that this is not uniquely UK or England. Yeah, so all of Europe, all high-income countries are entering a period of an ageing population, and health technology means that we can do more for people. So, so all countries are faced with the issue of how do you ensure that you meet that, and are anticipating a growing healthcare workforce, and globally, and this is one of the reasons why relying on international recruitment long term is such an issue. The WHO and the UN estimate, globally, huge increase in the demand for healthcare workers, outstripping at the moment global supply. So this is a reality, and it is in the good problems to have. Yeah, it is the result of the fact that people are living longer, which is part of what societies are here to do. And technology and innovation mean that we have the potential, to improve people's lives. We have a huge challenge of inequality in that experience in this country. But this is a problem that you want as a society. The question is how we respond to it, and whether we respond to it in a way which ensures that we're using those resources well, and we're using those resources well to benefit our economy. And obviously, one of the biggest drags on our economic growth is the number of people of working age who are out of work due to ill health. So the extent to which the health service is playing its part, and it's far from just about the health service, in helping with that is really important. Are we using health service resources really productively? Because our health service is 10% of our GDP. If it's not productive, our overall economy isn't doing as well. But then the point of that economic growth, the reason why that's pledge number one, is to benefit society, and to be able to do things that mean that people can live not just longer lives, but people can live better lives. And if we don't respond by ensuring that the NHS is there and able to flourish, what we will have is people still people working in healthcare, but deep inequality, as we'll have a bigger gap between those who are paying for it privately and those who are paying for it through the NHS. What I would say, I think, which is really important on the workforce, and one of the lessons we need to learn from 20 years ago, and I was involved at that time in the Treasury leading the team on the Oneless review that looked at future healthcare, is you want to do the workforce and capital investment before you turn on the taps. Because if you don't have the workers and you don't actually have the capital infrastructure, you can't spend the money well. And also you need to think long and hard about where you put those resources. So there were many good things done then, but actually an awful lot of that resource went to entrench a hospital model, not actually to do the shift in care, that saw a shift out to primary, community, mental health. And that's a lesson we need to learn now. So we need to do the workforce first, and we need to make sure that it's a workforce that is for the healthcare, the model of healthcare that we want in the future, and that is a workforce which is not about body parts, but is about genuinely integrated care. Because our analysis of those health needs is that there's going to be more ill health, but most people are living with multiple conditions. An awful lot of that are conditions, chronic pain, mental health, etc., that are primarily for management in general practice. And that's the bit of our service that at the moment we're now spending less of our budget on general practice than we were 10, 15 years ago.
Thank you, Nita. And yeah, there's quite a stretch target, 50% more clinical placements is the ambition in the long-term workforce plan for general practice. And sort of to that point, and sort of the changing burden of illness, Juliet, you've sort of given that example of how you might be able to foster a team-based approach to training, but you've also given the example as well about how expanding placement capacity in the community will be a key sort of plank. I just wondered, what are the key things so far in your conversations that are enabling you to create more placements, and then what lessons are there for other medical schools that will be thinking about how they're going to be able to expand those placements in the community?
Well, placements is always the challenge, and it's quite hard to go to your very stretched general practice and say, would you like to take X more new medical students, because they're likely to go, no room at the inn. So I think, again, it's about working with, certainly as a new school, we are, medical students will not be trained in a university. They will be trained in clinical practice. So giving more autonomy and choice to the clinicians who are taking our students is important. That is actually also about transparency of money and making sure that enough money goes. Using the secondary care model, anyone who's been involved in training medical students will know that a lot of money from HEE, for example, may not find its way to the consultant or the nurse who's actually training the medical student. So actually, I think if we work with our colleagues, particularly in the community, sufficient funds that then go to provide time in people's job plans, I think that's really important. For those clinicians who are teaching, a more portfolio-style job plan, if they can, I think helps their quality, their work-life balance. But also, the students who go out have skills, certainly the more senior students. Can they support the teams? Can they do roles? We saw students helping in vaccination during COVID, etc., so that they're not there, sort of, for want of a better word, getting in the way. And I think, one of the things we've done is where we have physician associate students, a physician associate and a medical student go out together to the placement. The placement says, well, look, actually, I've got a community nurse doing this. Both of these two can go with, or, so it's not just doctors teaching doctors, it's the whole team. And, that the education is really wrapped around the service to the patients. So I think it's a different model of working, basically. I think it's a different model.
Thank you very much. Now, Adrian, you gave a very practical set of considerations that would make doctors' lives better, both those in training and those that have been working in the NHS a long time. We have the Shadow Secretary of State doing an in-conversation here this afternoon at 3:00. What are the things that you'd like to hear him say at this conference that would make a difference to that agenda?
Okay, so I think if he comes up with a headline about let's make the NHS a better place to work, and that's setting a culture of making people feel valued, and that actually comes down to making sure it's got the adequate capacity for what it's supposed to do. We are under-doctored, under-nursed, under-bedded. This current government have said we are going to get 5,000 extra beds. They're nowhere near that. We think actually we're considerably short. Just to get through this winter, to get down to 85% occupancy within hospitals, we need about 10,000 beds. The Health Foundation will have a much bigger number for what comes out through the future. So actually increase the capacity so we actually make a more efficient and actually, frankly, a more pleasant place to be looked after in and to work in. That would be my big ask.
Super, thank you. And just a final question before we come to you in the audience, to you, Paul. One of the really interesting reflections, and I think this would be interesting to hear from you, given that you've had roles working across government, is this sense of health increasingly becoming everybody's business, the social determinants of health and how they bleed well beyond the Department of Health and Social Care. I just wondered how you thought a future government needs to approach that, to actually be able to consider in the round the sort of wider determinants of health, and then how you effectively work together across government departments and coordinate matters. Because when it doesn't work, and there are big ambitions, like, for instance, we're talking about workforce and the stresses fiscally that will place, these things there can be tension pretty quickly. So I wonder what you thought.
Well, Anita mentioned the One Loss report there, and you'll recall the was it called the fully engaged scenario, which was where he costed it against various levels of public health, and the only one that kind of worked in the long term was if you have a National Health Service where the citizenry is fully engaged in their own well-being and health, right? So the whole idea of prevention. And I suspect if we were to remodel that, it would be even more important now than it was when One Loss produced his report. Because of the growing population and obesity and all the rest of it. And talking of obesity, I've just lost 9 stone in weight, okay, over the last year and a half. Yes, go me. No injections and no. I've had my whole conference has been people either coming home saying you look great, or people coming home not knowing what to say in case I've been terribly unwell. Or people just blanking me because they don't recognise me at all, which has been astonishing. But my point of that is that it would have been quite nice, I think, to have been told before I hit 22 stone that I should have lost a bit of weight. And there was no medical intervention at any point, even when I had cellulitis, where the doctor said, have you thought about losing 5 or 6 stone? Because cellulitis is linked to your massive obesity. That the conversation never happened. I had to read Tom Watson's book and learn about this and do it myself. So I think the idea of intervention, early and prevention and lifestyle is going to be increasingly important. Now, the specific question was, how do we do it? I worked for a long time with Luciana Berger when she was the Shadow Mental Health Minister, and her idea was, well, it wasn't her idea, but what she was advocating was health in all policies, first of all. So some sort of way of evaluating government policy across the piece for its health impact. So a new transport scheme, a new school, whatever it is, how will this affect noise? How will this affect mental health, etc.? Pollution and so on. And that was going to be coordinated through the gearing system of a cabinet subcommittee where that would look at all these things across the piece, again, from a public health point of view. I think Wes is, well, you can ask him at 3 o'clock, can't you? But I think he's sort of thinking about that kind of machinery of government whereby you can coordinate. Because as we know from experience of government, immediately you start doing anything, the silos kick in, the turf wars kick in, the sort of rivalry between cabinet ministers kicks in, and that it makes it harder to do stuff. So I think you do need that mechanism where you bring them together in a sort of behind-the-scenes forum like a cabinet subcommittee, which I personally would advocate. I think that would work very well. That is one of the mechanisms to achieve that.
Brilliant. Thank you very much. Well, it's over to you. So do raise your hand if you have a question, and perhaps we'll take 3 in one go. So if we go over here, if we take the 2 ladies next to each other and this lady in the middle, and then we'll go to you guys at the back. Please state your name and organisation or association affiliation before asking a question.
Hi. Am I on? Yeah. Hi, I'm Sophie Bonnell from AXA Health. I'm just really interested in your thoughts on how this actually would be achieved in terms of funding, and particularly with the sort of points you've made on prevention. There's been lots of panels where we've talked about Treasury being sceptical around the funding when they're not going to see a sort of immediate impact. Does the panel have any views on how a Labour government might go about funding these proposals?
Lovely, thank you.
Hello, I'm from Diabetes UK, and I was very interested in what Paul had to say. And I think our insight suggests that it very tallies very much with what our insight suggests about GPs referring to being prepared to address issues of weight. And there's lots of reasons for it. One of them, I think, is the paucity of weight management services, and that's something that we're quite concerned about. And I think there's a workforce issue there in terms of at least one of the crucial elements of weight management services is having psychological support. And there's a big issue across the NHS, as you know, around people with mental health skills and psychology and psychiatry, and that really does need addressing, as we've got an increasing number of people living with mental health problems. Quite a lot of them, also living with obesity and diabetes too. So.
Lovely, thank you. And then to this lady in the middle.
Thank you. My name's Umi. I'm a local counsellor, but I also work at Adam Brooks Hospital as a paediatric dietitian. We spoke a lot about increasing our workforce and increasing the number of spaces in medical schools and nursing schools. How do we navigate the fact that it's our current burnt-out workforce that will be training these people? Yeah. Do they have the capacity, and will this lead to more of a reliance on overseas recruitment and so on? Thank you.
Great question, thank you. So a question on the fiscal challenge, funding, a question on weight management services, I suppose multiple conditions, paucity of services, how we join things up, and then that really critical question, thank you for that, around clinical educators and actually who is going to educate the education. Perhaps maybe if we work our way down the line and you comment on whichever of those you would like.
Probably makes sense for me to comment on the money and the fiscal challenge. And I think this is something which is really important to think through. And Wes Streeting has been talking a lot about the health issue being a 10-year agenda. And I think fundamentally, actually, it's really difficult to see any path to major improvements that doesn't take that very long-term perspective, given where we are at the moment. In order to do that, we know that we need to spend money differently, as well as potentially spending more money. And so I would argue, I think, that in the short term, we need to focus any available funding on 3 areas. On training the new workforce, because and we need to give people hope. People in the workforce at the moment, part of the retention problem will be convincing people that it won't always be like this. Yeah, and that working in the NHS won't always be managing chronic shortages at the start. So we need to train the workforce. We need to invest in capital, in things like in a proper digital infrastructure that also mean that we can join up care across patients, but also for staff, the deep frustrations of, when you go to work, you almost go back in time 20 years compared to the rest of your life, and functioning IT and basic technologies don't exist. And critically, we need to invest in prevention. And spending per head of population on the services under the public health grant, which are, support for children under 5s, weight management services, obesity services, smoking cessation services, drug and alcohol, that's fallen by a quarter. Since 2015, and yet that's some of the most cost-effective treatment. And I think the hard thing here is going to be, and we're going to see this at the moment this winter, is that hospital services are under extreme pressure, and hospitals are likely to go into deficit. And so always what happens there is the money gets pulled out of all of those things that we know in the long term are the right things. So part of the challenge, I think, for an incoming government is to think, how do you hold on to and protect the areas of spending that in the long run are the only ways out of this? And so I've done some work with Demos recently on the idea of creating a new category of ring-fence spending across government on prevention. In order to try to, again, and so that when we can see it, so it stops being the easy thing we can cut when things are difficult, and things are going to be difficult for a very long time. But also then we can also be clear that not all spending is the same, that if you're investing in capital, you're investing in the workforce, you're investing in prevention, actually that's creating an asset for the future. Right. And we should see that differently. And responsible government invests in the future, yeah? So it's slightly different to the argument about continually living above your means. It's part of how we get to a sustainable system of our economy and public services.
Thank you. Adrian, any comments on those questions?
Yeah, so I, as an emergency doctor, I regularly get asked, stop lobbying so hard for your sector because you're taking money out of the prevention budget. It's almost like you're taking vaccines out of babies' arms. It's not true. You need both. It is a false dichotomy to say that you're arguing one needs to be prioritised. You need both. You need both excellent preventative care, and you also need excellent medical care. The consequences of not providing excellent medical care are the problems we're seeing in our hospitals at the moment, but also massive litigation. And we need to make sure that we're doing what we can to minimise litigation. I am in the most sued, in terms of the number of claims, medical specialty. In terms of training capacity, excuse me. Sorry.
Have some water,
yeah. We are a country that imports our healthcare staff from around the world. We've got to do this ethically. You know, everyone is getting really excited about doctors going to Australia. We are continuing to take nurses from the Philippines, doctors from India and Pakistan in a way that actually makes us look a little bit asymmetric. The numbers coming in are much greater than the numbers going out, and we need to make sure that is managed ethically and actually provides benefit for both sides of this. I go to some really uncomfortable meetings. I went recently to an international congress where the head of my equivalent in the Philippines says, we've closed these emergency departments, we've closed these dialysis units because they've all gone to work in Europe, Canada, Australia, the US. So whatever we do has to be ethical. There is undoubtedly a challenge about maintaining the training capacity, but it is something that senior doctors like doing. Most senior doctors like bringing along the new generation and seeing them become good clinicians. It's something that we would want to do if the environment, the terms and the conditions, but the lines between you're here to train, here's the time, here's the money to go and do the training, and actually being able to deliver it, I'm sure this is a problem for the medical schools particularly, are very hazy. A university will give some money to a hospital to do some training, the money goes, and it goes somewhere into a black box, and then the clinicians are told to go and do some training.
Juliet, if you want to comment on that.
Yeah, I will comment on that. Yes, that is my life's work. But just going back to the funding issue, Sophie's question, I mean, just to, I suppose, make it clear if there are medical schools like ours who are just setting up. At the moment, we are only able to take international students, which, you know, we're very pleased to do, but I think that does certainly something that needs to be, and of course everyone supports that, but, you know, I think a speedy resolution to allow schools that are up and running, that are accredited to train you know, home students is really important when we look at the challenges that we have, and also reflecting on the points about obesity and social determinants of health. I think, again, medical schools have a responsibility to modernise their curricula so students are out there seeing that. Medical training has been very secondary and probably tertiary care focused, hasn't it, for a long time? So a different model. But the yes, the old friend about how to get a tired workforce to teach medical students is all about transparency of money. It's all about transparency of money, and one of the beauties of setting up an independent medical school is the financial rigour with which we have to do it at the beginning, because this is a different source of money. But an example was an A&E colleague actually in Brighton. The department had such problems with staffing and retention and illness in its junior doctors. The locum budget was just huge, and we managed, particularly because of the canniness of that particular clinician, to say this is the money that comes into the department for teaching, follows the students, and you use that money to create fellows. These fellows contributed to the rota, therefore the locum bill went down. What they did was they owned the teaching, which allowed the consultant not to be faced with 15 medical students when he's got 100 patients, but to be able to own the teaching, and then the consultant can contribute as he wished. The GMC feedback for the trainees much improved. Actually, there's fellows who are doing, 50% teaching, 50% clinical work, could then help with some audits, could then do some pilots. And from what was essentially just using the money the way that it should be, it changed the tone, and they won HSJ awards for that. So that principle out in primary care, I think, is the way forward. Easier said than done, but I think if you start clean, you can continue, I think.
Brilliant. Thank you very much. And reflections from you, Paul?
I mean, if I was a special advisor again, I think I would go in and just some of these preventative measures would be more salient. I don't remember really talking about it that much in the department, and I mean, certainly mental health was almost hardly ever mentioned in terms of departmental priorities. The work was going on, but it hadn't got the elevated levels of the private office, and so all of those things are so different now. And I think, I mean, Wes gets this. He knows you've got to have the preventative agenda. On mental health in particular, I mean, is there another system where, you have to wait till you get to a certain point of illness before you get seen and treated? Imagine if we did that with cancer or an abscess or something. It's just ridiculous, isn't it? It's the opposite of preventative. It's actually letting it go to its extremes before we treat. So I think history will judge an enormous mistake of cutting those public health budgets over the last few years, and cutting out things like smoking cessation and obesity and sexual health and all the things that are easy targets. But I do like the idea of ring fencing, and I think some sort of even hypothecation actually, but some way of locking it in so you can't just have that as an easy target for cuts, I think is a good idea. We spent the morning in this room talking about something completely different seemingly, which was the rise of shop theft. But it's not, is it? Because if you prevent people with addiction problems from being addicts and you treat them, they're not going to go and start robbing the shops. And if you're not robbing the shops, you don't need the police, and you know, the courts, and it all interlinks in terms of public expenditure. So I suppose my sort of final point is that we need to get that magic equilibrium of joined up government, you know, where I know we've been talking about it for 30 years, but we actually do join these policies together. And the Cabinet works as a team to actually deliver these social issues, solutions to them in a joined-up way across departments. Because if we just go back into our silos as a Labour government, we're going to repeat all the same mistakes, aren't we?
Thank you very much. And we've got time to squeeze in a couple of final questions. So perhaps we go to the gentleman in the aisle here, and the gentleman on the very, very back row is waiting. So those two. And then we'll give our panellists final reflections response. So name and organisation, please, sir.
Thank you for a really engaging conversation. My name is Obi Jude. I'm an orthopaedic consultant in London. And we're in a catch-22 in that we are struggling with retention, but we are training more trainees and we don't have consultant posts for them. And we have this culture where we're almost exploiting these locum consultant contracts. We burn them out and then they're not offered posts. And I personally know a number of well-trained, fully trained consultant surgeons who are not working because there isn't a consultant post for them, or they're stuck in endless fellowship. So how we're going to catch up and see more patients, I think, is expanding the consultant body. Is there any plans or what's in the pipeline in terms of that?
Great question, thank you. And the gentleman right at the back, name and organisation, please.
Thank you. I'm Paul Bates from Terence Higgins Trust. HIV sexual health doesn't get a mention at all in the workforce plan for the NHS. We know why, because of the funding via the public health grant. But how do the panel think we can better integrate NHS services and local services and commissioners funding via the public health grant? Because at the moment the disconnect is enormous, and as the panel's already conceded, we're seeing a significant underinvestment in some of those preventative services, including sexual health. And the recent data shows that STIs are actually going through the roof, but the investment is going through the floor. So how do we align this better?
Yeah. Great question. Thank you very much. And so I'll sort of go down the row if that's okay, and final comments as well. So Anita first.
I mean, just to reiterate the point about sexual health, and the rates are very substantial. And of course, if you think about the implications for young women in terms of their subsequent life and their fertility, this is one of those things. We've come out of the pandemic in a really bad place. And often a lot of those women's health issues don't get the same focus, and it's a textbook example, I think, of where a lack of focus on prevention and those earlier services is going to lead to some consequences that we as a society will profoundly regret. The issue about, workforce planning, it's really important. One of the things that I think has been a real problem in some of the workforce planning for the NHS is that it's done NHS workforce planning and without recognising that actually for the NHS to be effective, we need all of the health and care workforce planned. Yeah? And I think making sure that workforce planning, which does now seem that there again is cross-party support that we need to do good workforce planning, that genuinely becomes health and social care integrated workforce planning is one of the things that I would hope that we would see. And I think to the point about the junior doctors being able to progress to consultant, I think this is a really important question, and and something to look at when we unpack why we've got strike action for junior doctors at the moment, and more importantly, almost than why we've got strike action, why we've got a workforce that should be that is early in their career, in great potential jobs, living the thing that they have wanted to do, you know, from a very young age, and so young, feeling so disengaged and demoralised. That's what we've got to think about, and we've got to think about this as a career and whole work practice. And I think the industrial action is telling us something deeper. And actually, I think the response to it has got to be to understand those deeper questions and think about the range of things that are going wrong.
Thanks, Adrian.
Okay, so the long-term workforce plan came out, and it is much better to have a long-term workforce plan than not. But if you're sitting in a hospital, you might look and go, where is the comment about training places? And training places, where's that going to lead? Because there was nothing about it. And you know, the long-term workforce plan was under a lot of blankets for an awful long time. And you know, if you were being critical, you might say, where was the modelling? Where was the modelling around the various specialties that we're going to need to do all of these bits of work? Consultant posts depend on hospitals deciding to employ them. I think there is also a question about the changing role of a consultant. When I became a consultant in my department, I was the 4th consultant. My job was running that department. I now am one of a team of 35. You can't have 35 people running a place. That's a disaster. And actually, there are conversations which need to come down the road about what a consultant is expected to do. In terms of prevention, I completely understand where you're coming from. Budding stuff off into community services and taking them out of the NHS, it's a good way to disinvest them.
So I was just moving on from the previous comments. I completely agree that it's such a shame to hear that there are consultants, that fully trained consultants, that you're describing orthopaedic consultants not working. And I think in planning roles in the future, I think it's really important that we think about the other aspects of being a consultant, so teaching, research, leadership, mentorship, professional development of those trainees, those students. So that sort of wrap-around expert specialist role that a consultant can play, meaning that we're not disjointed. Everything, as you're saying, Paul, joins up, you know, and I think that's a really important part of workforce planning, is to look at the bigger picture. And I completely agree about placements outside what we might say were traditional hospital placements. It's really important that students see that work, see that care, see those specialists, and with that should come the funding that follows a student, which will also then, you know, as my example from the A&E department, will help those services. So a much more joined up approach, I think, would be really important.
Thank you. And the final word to you.
No, I'm happy to defer to my elders and betters.
Lovely. Well, like that, we've sort of perfect sort of natural stopping point. So apologies to those of you who wasn't able to bring in on this occasion, but just to say a big thanks to the University of Surrey for their support of this event, and I hope that you'll join us at 3 o'clock. We have the Shadow Secretary of State in conversation with Andrew Marr in this room, and do obviously enjoy the rest of the programme that Policy Exchange is coming on, but please join me in thanking our expert panel.
Very good.
Thank you very much.
Well done, Chair. Very good. Dead on time. Impressive.
Yes.
I know.